Gargee, you represent yet another source of potential funds where governments and multilateral donors often have many restrictions about when and how they can contribute. Foundations generally have more flexibility and freedom. Can you comment on how foundations use their balance sheets going beyond grants to encourage crowding in from other funders?
Sure, happy to. It's nice to go 3/4 of the way through the session because there are so many good lines to steal. So I think my views on this are summarized in two sort of pithy statements that were already made. In terms of what donors, public donors can do versus a foundation, I think when there's a political will, there's a way, as I think Edge said yesterday. In terms of what donors should do, us and others, I think someone this morning said the best insurance is to build, in our case, primary health capacity. So let me give you maybe the 4-minute version of those two sentences from our view. Here's what we did in terms of Ebola response. Like Tori, early on in June or July, we just made very rapid emergency cash grants to WHO and to Unicef. Oh, thanks. And then in September, we made a more sort of studied announcement. We continued emergency grants to CDC and Unicef, and we announced about $60 million worth of grant making on four areas that in our assessment were priority areas. First, mobilizing global organizations to accelerate their action. We spent about $13 million on that. Second, investing in R&D for new Ebola interventions. We spent almost $30 million in that area. Third, supporting the 3 deeply affected countries by working with their emergency ops centers. We spent only about $10 million there because that's where so much of the money was flooding in, and for helping border countries prepare for outbreaks and preventing the further spread of Ebola. As was raised yesterday, we saw our role during the crisis very much as cash. But we wanted to be providers of cash with sort of deliberate strategic intent. So I think what's notable maybe about that in light of your question, Trish, is what we didn't do. We didn't do anything fancy. We didn't do guarantees. We didn't do pledge guarantees or production guarantees. We didn't do first loss facilities. We didn't talk about another IFM for the simple reason that those all take too long. Many of us in the room have been involved in many of these innovative finance facilities, and I was thinking about this morning. I think the shortest amount of time I've seen these happen when there's a kind of public-private partnership involved is kind of 8 months. Maybe I'm being too optimistic. Tori, Edge, others will have a view. We can all put our bets. But you know the message there is obvious. Either you have to have the snow plow contracts in place in advance, as Olga said yesterday, or I would advocate that we're at a stage, I think, where we know that some of these mechanisms are so useful for health financing in general that we should just get really good at things like guarantees so that they're part of more donors' regular book of business and we can move faster on some of these mechanisms. So I'm a big fan of not one-off innovation for its own sake, but incorporating some of the tools that we know are useful more regularly into our practices. A few things that we're doing now, I think that we do have a little bit more breathing room to think in advance. As Tori said, we're continuing to push hard on the R&D agenda. I don't think it's happening enough, and I think that deserves concerted attention. Similarly, we're continuing to work with some of the countries on emergency operations centers. But our real push, I think, is to take the moment in the wake of a pandemic sort of emergency mode and convert that into a sense of emergency around primary health care. And we really see, like others, that this was a failure of health systems. And so we're very focused on primary health care strengthening. For us, I think a really big win would be building some consensus in the global community around a key set of indicators for what constitutes a basic primary health care system that is able to do routine functions, the bread and butter, but also is ready for to scale up in the event of an emergency. So we've been working with many others in this room and outside on a core set of primary healthcare system indicators. The other area where we're really doubling down is surveillance. In our view, this was part of the system, obviously, but this was also a failure of surveillance and early warning. We are investing in something called the Child Health and Mortality Prevention System, CHAMPS. It's meant to be a network of data and surveillance centers around the world. We're starting in 6 countries. We're hoping it will end up being in 20 countries to basically track primarily child morbidity and mortality data with the explicit intention that these provide both a routine service but are also ready to scale up and be trainers of trainers in the event of an emergency. So that's what our footprint looks like.
Great, thanks. One of the themes in the Financing for Development conference in Addis was that there are a range of new pools of money available for development, and we've heard that again here. Among these pools and or among the various tools that you just talked about, what do you see as the best options for funding pandemic preparedness and response?
So I don't think there are new pools. I think we keep hoping that they are, but we kind of know what the pools are. I think there are domestic resources. I think there's private for-profit resources, both FDI and capital flows. I think there's ODA, or official flows, for those donors who don't want to be part of the DAC. And then I think there are out-of-pocket payments, either domestically, sort of individual payments, or internationally remittance flows. And those have basically been the same flows for a long time. They sort of ebb and flow in relative importance, and those ebbs and flows are important. So I think ODA's pretty flat, $130 billion a year, about 12% of that goes to global health. Maybe we'll push that up a little higher, but I don't see, we're not betting on that growing dramatically in the next few years. So I think in official assistance, it's really about recycling capital better, looking for efficiencies. I personally think sort of public procurement is a place to focus. The sort of cash on hand procurement model is a source of major inefficiency in our system. But I think it's that kind of thing, leveraging the balance sheet, as Tori said, in ODA. I think on domestic resources, Jennifer, you talked about that a little bit. There's a bit of fairy dust now about how we talk about domestic resources, but you know, the experts in this room know even better than I do how hard that is to change, even by 1% or 2%, tax to GDP or revenue to GDP. But you know, I think where we're heading in this conversation and on pandemic financing maybe is an acknowledgement that you know, the routine bits of preparedness that are about the health system need to be a shared responsibility between donor and developing countries, and we need to be serious about the plan and the targets and what we're trying to achieve on the routine bits. And then the emergency sort of ex post is going to be an externally financed need, and we need the triggers and the systems, the processes, the mechanisms to finance those, and that's very much what we've been talking about yesterday.